Dear colleagues from Europe, dear colleagues from all over the world, fortunately, we had a lot of adherents from many countries. Please feel very welcome to this webinar. I am very happy to have you with us, and I'm also very happy to have John Brodersen with us. John is a colleague, he's a family doctor in Copenhagen, in Denmark. He's also a researcher and a teacher in the Faculty of Medicine, the name he will say after. And he has done a lot of research in the field of overdiagnosis and overdiagnosis prevention. And he is also the Danish delegate to EUROPREV. EUROPREV, as most of you know, is the 1K Europe network for prevention and health promotion. Hi, John, how are you? Thank you for being here, and please say hello to our colleagues.
Hello, everyone, and thank you for attending this webinar. I'm very pleased to been invited and talk with Carlos tonight about the EU's new recommendations on cancer screening.
Okay.
I can tell later where I'm affiliated when I show my slides.
You are going to show a picture.
Yeah.
And that's great. How was your day today, John? A lot of work?
A lot of work. First of all, a morning where I prepared my slides for this webinar, and tomorrow I'm doing a keynote on a seminar for the Danish health regions, because I've published a book very recently about overdiagnosis, actually a textbook for university students. But it has been received so well in Denmark that now all the health authorities, they want me to talk about what is in the book, and I'm doing a keynote tomorrow. So I also had to prepare that. And then you have this, you know, the little devil sitting on your shoulder, the inbox of your email, and it's ticking all the time. So yes, that has been my work today. No clinical work today.
Okay. So it's wonderful, and it's great to see family doctors being heard by politicians and by the society. So it's always important for us to be able to share science-based opinions. John, we already have some comments from our colleagues. They are telling us good evening. For example, Marina Ivanovic, good evening from Bosnia. Maria Bacola, hello from Greece. Hello, Maria. Elena Simurna, greetings to all. Everything is okay. Great, Elena. Carla Gouveia from Portugal. Okay. Good evening, Carla, and thank you for being there. Ana Luisa Gomes also. Okay. I believe we are ready to go. So I'm going to share my slides. Just a minute. Okay. And I'm going to do a small introduction. First of all, I have televote questions. I will share here a link where you can access to the televote. And I would appreciate if you could answer to this question that I have here for you. And later we will show your answers. So you can access this link that I shared in the platform, in the web chat platform, and please answer to the televoting question and remain this link open, because later we will have new questions for you to televote. So please do answer this question that I'm sharing with you. Okay, so now I'm going forward. The topic of this webinar comes in context of a new European Union proposal related to a new approach on cancer detection, and they are proposing new cancer screenings. The first draft was launched on 20th September last year, and then there was some discussion, and then at the European Council of the Health Ministers, this first draft was the proposal by the European Commission, but then in December, the European Council of Health Ministers approved the final version. And there are some differences between the initial proposal and the final one that was approved. I am going to show you the difference. When we, EUROPREV, read the initial proposal, we got very worried about it. And we started a discussion among us, and we decided to make a statement that was launched and is in our website, calling for some changes. And I believe this statement was important, and it's important, as I was saying, that family doctors make their point of view science-based, evidence-based points of views. So here in the left, you have the initial proposal. In the right, you have the one that was approved. In the initial proposal, there was the intention to extend the target group for breast cancer screening to include women between 45 and 74 years of age. In the final version that was approved, breast cancer screening with mammography is recommended for women aged 50 to 69 and only suggested to the other age groups. Then, regarding prostate, lung, and gastric cancer screenings, in the initial proposal, there was recommendation to initiate organized screening to these 3 additional cancers. At the end, in the version that was approved, they only invite member states on the basis of further research to explore the feasibility and effectiveness of these 3 cancer screenings. Regarding in concrete to lung cancer screening, the initial proposal was proposing for current heavy and ex-smokes low-dose CT screening for those aged from 50 to 75 years, and in the end, to explore the feasibility and effectiveness of low-dose CT to screen these kind of individuals. Prostate cancer screening was recommended in the initial proposal to men from up to 70 on the basis of PSA testing and MRI scanning as follow-up. Again, to evaluate the feasibility and effectiveness of organized prostate cancer screening for men on the basis of PSA plus MRI. In the initial proposal, there was the proposal, the recommendation of screening for Helicobacter pylori and surveillance of precancerous stomach lesions in places with high gastric cancer incidence and death rates. And now they consider to follow screen and test strategies for Helicobacter pylori for countries and regions with high gastric cancer incidence and mortality. They also recommend, and this remained unchanged between the initial version and the final version, the testing for HPV and the fecal immunochemical testing as preferred screening test for colorectal cancer screening between 50 and 74 years old. This is, in short, the new European Union approach to cancer detection. And now, dear colleagues, I'm starting a new televoting question, so please once again, do vote and answer to a new question in the televote. And then later we will show you your answers. So, John, why were we, and in fact we still are, worried about? And now I would like you to show your presentation. I will stop my sharing of the screening. Just a minute. It's not here. Oops, sorry. And you may start sharing your presentation, please. So meanwhile, I'm going to read some topics from our colleagues, also from Croatia, Domizani, Caroline from Malta, Marisa, Anna Christina from Ukraine. Hi, Anna. I hope you are safe and well. Xenia, good evening. Hi, Xenia. Anna Mateus, good evening, all colleagues, and thank you for this webinar. You are welcome, Anna. Isabel Cunha, good evening to all and Happy New Year. Happy New Year to you too, Isabel. Okay.
Can you see my slides now?
Yes, we do. So,
okay. And thank you again for the invitation, Carlos, to talk about cancer screening, which has been a subject of my research for more than 20 years. I actually did my PhD on screening mammography and false positives. But I'm a GP and I still see patients, not so often anymore. I take a week off in my busy calendar from my research and teaching because I'm a professor at the University of Copenhagen in Denmark. My professorship is placed at one of our health regions called Region Zealand. I'm also a visiting professor in Norway, North Norway, Tromsø, north of the polar circle. Anyway, let me see. Yes, my talk is based on this new textbook that I published in September together with Alexander Jønsson. It's for now only in Danish, although we have a draft of the front page in English, and it's in Danish called "Soon We Will All Be Patients." And my talk will be based on that book. I'm also involved in this society called Preventing Overdiagnosis, which we have biannual conferences. And as you can see, this year we actually have the conference in Copenhagen. I'm hosting it. You can call it a conflict of interest, but I just wanted to announce it also as a potential conference where you could attend if you're interested in the subject of overdiagnosis. My content will be this. I will try and set the scene. Then I will say something about pros and cons of screening. And then I will go through the 6 cancer screenings that Carlos just presented that was included in the EU proposal. Setting the scene, I think it's valuable to take the core values that we have now written and is also a part of Onco Europe now. And 2 of the core values actually touch the area that we're talking about today. The core value 2 says, we provide timely diagnosis and avoid unnecessarily test and overtreatment. Disease prevention and health promotion are integrated in our daily activities. And if you go and look at the small text, we have in the second paragraph, over-examination, over-diagnosis, and over-treatment can harm patients. But as the opposite, consume resources and indirectly lead to harmful underdiagnosis and undertreatment elsewhere. So it is a concern of general practice. There's also the thing around social inequity. We prioritize those whose needs for healthcare are greatest. And I will talk about those two core values in my presentation.
John, just let me share with you and our colleagues that this is exactly in line with also the family medicine core values that were approved by Wonka Europe, that are all European GPs core values. So, and we have a topic that is science-based, related, and it's important to keep this in mind.
Yes, and it all started in Norway, where they did write 7 core values, and then it went on to Denmark, and then it went into the Nordic Federation of General Practice, and now we have included as a part of Wonka Europe's core values. So it's a great thing to see how this has spread during the last 15 years.
Yes, I agree.
Just to define what I'm talking about today, screening is something that is going on in the population among apparently healthy people. And it's people that are asymptomatic from the condition that we are screening from, while diagnosis is defined as something that is going on in patients with symptoms. And it's of course not a dichotomy, it's not black and white, as this figure from WHO is showing. It's more like the arrow at the top, where you have a continuum of symptoms. And that is, of course, making this much more complex, but it's just to define the two terms, early diagnosis and screening, how they are different. We know from evidence-based medicine that if we look at a group of patients and we do an average calculation of the benefits, this benefit is only an average of the group. But if we go from group level to individual level, we could regard our patients at a risk calculator, which is here appointed at the bottom. So if you imagine you have a very low risk patient with a very low risk of events, and you have a patient with very high risk of events, then the benefits are not equal to those patients. Those at highest risk will benefit more. However, harms are probably equally spread out on that continuum. And that makes this figure that you will cross somewhere between low risk and high risk, where the benefits are greater than the harms, or the opposite. It also, of course, depends if the benefits are really low, very few, not very severe, very mild, or the opposite, where you can actually have more harms. At the end, you will come to the conclusion where you will have, in one end, more harms than good, and on the other hand, more benefits than harms. And this discussion, if we take blood pressure as an example, is always where to put the cutoff. Where should we start treating patients with a certain blood pressure? This also shows you that the two patients with the same blood pressure will not benefit equally, but will probably be harmed equally. So treating, for example, hypertension is not a number you should treat, but a patient you should treat. When we look at the research that is starting now about sustainability in healthcare, you need to know the numbers 60, 30, and 10. 60% of what we are doing in healthcare is called effective care or high-value care. 30% of what we are doing has been estimated and valued as low-value care. And 10% of what we're doing is specifically harmful care. We also know that the carbon footprint from the healthcare system is coming mostly from clinical activities and not from heating our buildings or lightening it. So it is what we are doing as health professionals that is making the carbon footprint. It's actually been estimated that 80% of the carbon footprint comes from clinical care. And from this, you can see that you can actually reduce 40% of what we are doing, and 40% of 80, that is a little more than 30%. So we can actually reduce our carbon footprint by 30% without harming anybody, but actually helping a lot of patients. And this part of the 30% of low value care and the harmful care of 10% comes from too much medicine, which I have drawn a non-evidence-based figure. It's just to illustrate that these terms, these concepts are overlapping. So you have overuse, you have over-testing, you have overdiagnosis, and you have over-treatment in the too much medicine area. And that is all contributing to the low value care and harmful care. When we go to screening, when we look at the screening cascade, this figure is from Ross Harris and colleagues. You can see it's a quite complex thing, screening. Often it is looked upon as something very simple. However, the cascade can go in many directions. If you follow the person that is screened and get a positive result, then this person needs a workup. Here you have 4 outcomes: true positives, false positives, something indeterminate, and then surveillance. When you go to the true positive result, which is always in focus when we are talking about screening, there are actually 4 different true positive results. Only one of the boxes people will benefit from the screening. You will have those in the 2 yellow boxes that die anyway or survive anyway, no matter the screening. And then the gray box here is people that are overdiagnosed. So only the left corner, where you see that the early treatment is the person is getting a better prognosis, here you will see a benefit. And it's very important to notice that the benefit here is probably a longer life at the end of life. So it's at the end when you are maybe 80, 82, that you will live some months or some years longer. When you look at the outcomes from pros and cons in screening, then the beneficial outcomes are reduced mortality, morbidity, incidents that are likely to occur in some screening programs, and then you can also have less radical treatment. When you look at the harmful outcomes, then it's longer morbidity, overdiagnosis and overtreatment, the 2 false results, induced disease, increased fear for being sick, and increased mortality, and it should say morbidity, sorry for the spelling mistake. I have been very interested in those outcomes that I show you here, because in evidence-based medicine and in research, they are all sometimes quantified. However, composite outcomes or other kinds of outcomes are never measured. And here I've tried to illustrate longer morbidity as an outcome. In the top arrow, you have a person that is overdiagnosed, and this person is living a very long time, having a diagnosis, being a patient that is unnecessarily. Then you have all the persons attending the screening, getting a positive result, and they will all live longer as patients. And only at the bottom arrow, the person will live longer and have a benefit from the screening. And we do not talk about this harmful thing, having longer morbidity. It is never estimated and is nearly never discussed. And that I find is in an evidence-based way and in a professional way wrong, and it should be taken into account when we discuss screening. I cannot go through all those benefits and harmful things in screening, but I will focus on those 3 important outcomes: reduced mortality, overdiagnosis, and false positives. When we look at the reduced mortality, I have an example here from the colorectal cancer screening trial from Minnesota. It's a FOBT test, fecal occult blood test, where you screen people for colorectal cancer. And from this curve, you can see that annual screening, you will have a smaller mortality of colorectal cancer than biannual screening and no screening. So there's a beautiful dose relationship, and it shows here with very robust evidence that colorectal cancer screening with FOBT test is reducing mortality of colorectal cancer. But now I will challenge you a bit, because now I will show you the same cohort, the same study. I will just change the mortality from the cancer-specific mortality to overall mortality. And in the next figure, there are also 3 lines. Here you can see no reduction in all-cause mortality. So from these huge randomized trials, where we have actually here followed people for 30 years, we cannot see any difference statistically when we look at expected lifetime. There might be a very reasonable explanation to this curve, and that is that colorectal cancer is not contributing a lot to too early death. We did a paper here from the 5 Nordic countries where we looked at mortality reasons among people from 50 to 74. And as you can see here, around 5% of people dying in this age group, they are dying from colorectal cancer, while around 2/3 of the people are dying from smoking-related diseases. Screening with FOBT has shown a reduction of colorectal cancer mortality of 15%, and 15% of 5%. That's around the one you see here, 0.8%. So that is the expected effect we can get from colorectal cancer screening when we look at all-cause mortality. And it's not, this pattern is not only for Denmark, this is from all 5 countries. So what we can say is we have started here a cancer screening program. Not a lot of people die early from this disease, and therefore we will not have a huge public health effect on all-cause mortality. And that is not really feasible to show in a statistical analysis. And that is probably why you saw the 3 lines looking equally at the all-cause mortality. And because we have these very, very small absolute effects on all-cause mortality, we need, when we look at the evidence of screening, we need high-quality randomized controlled trials when we decide whether or not to screen. And we need thousands of people in the trials, and we need to follow people for many years. And this is a very, very important thing to notice. So when you judge if a screening program is effective or not, please provide evidence from randomized controlled trials, big ones where people are followed for many years. When we look at overdiagnosis as an
a question from our colleague Carl. Carl asks, why should we give more importance to all-cause mortality than to cancer-specific mortality? I think that was the question, because he wrote cancer again. Should a cancer screening really be expected to reduce all-cause mortality? So I believe the question is,
if you have a cancer that is very common, if you have a cancer where people die very early, then you should expect that the all-cause mortality is reduced. If you have a cancer that is very rare, if you have a cancer where people don't die very early in life, then you should not expect a reduction in all-cause mortality.
Okay.
The problem about doing prevention among a huge population using millions of euros to do this kind of prevention and not really getting any benefits from living longer. And that is what the outcome all-cause mortality is about. Is that worth it? Shouldn't we do other kinds of prevention then? We could do structural prevention on smoking and prevent a lot more from that with the same kind of money. So this is also a discussion about values, priorities, ethics. And when you go into values, ethics, priorities, I mean, you don't have one answer, you have 100 answers. So I'm not, as a professor, to say whether you should value a screening program on all-cause mortality or specific mortality. I'm just trying to provide a discussion how you value the evidence, how you look at the evidence from screening programs. And then you can discuss your own values and take the political discussions.
Okay. Some colleagues apologize for example, there are some cancer screenings where the randomized control trial show the specific reduction in the specific mortality, but not into all-cause mortality. If a colleague from other specialty comes to you and argues about that, what kind of arguments can we family physicians use to discuss this kind of issue and difference?
I think we need to include a lot of different issues, topics to that discussion. We need to talk about, is this disease a disease where a lot of people get it? Is it frequent? Is it a disease where people die very early and you can actually expect that you gain a lot of years to live if you get early treatment and thereby get a better prognosis? You also need to look at the cost, and then you need to compare it to primary prevention. The good thing about at least structural primary prevention is that you never harm people. And when you look at my slide here, there's a lot of harm in cancer screening. And let's say you have a reduced mortality that is specific, then I would argue you have to balance the benefits and harms here. However, we don't have any scientific ways of doing that. And then we go into the discussion around values. Okay. So how many prevented death is accepted to how many overdiagnosed healthy people? So how many can you allow you are harming and then preventing deaths among those with diseases?
Okay, thank you very much, John. Can you see the results of the answer? So you are going now to explain and to talk about overdiagnosis, and we had this kind of vignette. Rosa's mammography result told her she probably has the diagnosis of breast cancer. But then last week, she received the result of the biopsy, and it's a benign lesion. She has not cancer. In your opinion, this is a typical situation of breast cancer overdiagnosis, and 52% of our colleagues say this is a typical situation of breast cancer overdiagnosis, and then 48% this is not an overdiagnosis. I would say this is a false positive.
Yeah, I agree.
I would say you have to explain well the concept of overdiagnosis, at least to 53% of our colleagues.
I will try to do that.
Okay. Yes, you can share your slides again, please. Okay, already are.
Yeah, and I have written this editorial where with some great colleagues, and we are trying here to define what overdiagnosis is.
It's a great paper. Congratulations for it.
Thank you.
I really love it, and I use it very often.
Thank you. I think it's quite easy to say that overdiagnosis fulfills all the diagnostic criteria. So in the paper here we write, broadly overdiagnosis means making patients unnecessarily by identifying problems that were never going to cause harm, or by medicalizing ordinary life experiences through expanded definitions of diseases. And if you look at two of the authors' other paper, together with Gilbert Welch here, it's very important to include prognosis in the discussion around overdiagnosis, because it's a diagnosis that fulfills all the diagnostic criteria. However, the ultimate criterion for overdiagnosis at the end of life, if the person never developed a problem from her condition, she's been overdiagnosed. And in your case, Carlos, the person was further examined and it showed no malignancy in the biopsy. That's a false positive.
Yes.
If it had shown malignancy in the biopsy, it could have been correctly diagnosis, or it could have been overdiagnosis.
Exactly.
And if you think back to my cascade, there are 4 true positive results, and only one of them will benefit from the screening. Only one of them is overdiagnosis, and then you have 2 groups where it's correct diagnosis, but they will die anyway or survive anyway the disease, no matter the screening. The reason why we have overdiagnosis is those very slow-growing or non-progressive cancers, here illustrated as a snail or a turtle. We also have those that we don't catch in a screening program that are fast-growing, and those we often illustrate as bird cancers, while the bear cancer is the ones that might benefit from being identified in a screening program. So it's the growth rate. Another reason why we have overdiagnosis is the competing risk of death. So if you have a short lifespan left in your life and you are diagnosed with a cancer, you might not ever get symptoms from that cancer because you might die in 2 years from other reasons. So that's a second reason to overdiagnosis. And a third reason is the technology you're using. So the more sensitive your technology is, the more you can find in cancer screening, and the smaller cancers and slow-growing cancers you can find. This is an illustration of that. That is from the Danish randomized trial on low-dose CT screening for lung cancer, where this person had this nodule for 4 years, had surgery in 2009, and it showed invasive lung cancer. And here you can see it's a very, very slow-growing cancer. And when you are a heavy smoker, you have a very high competing risk of dying from other reasons. So this person might have been correctly diagnosed or might have been overdiagnosed. Paul Glasgow, a good and dear colleague of us, GP professor in Australia at Bond University, has done this great paper around how many of all people diagnosed with cancer in Australia are overdiagnosed. Here you can see there are 4 cancers that are have a lot of cancer or cancer overdiagnosis in women: thoracic cancer, renal cancer, malignant melanoma, and breast cancer. When you look at the combined cancers in the bottom, the 2 red areas is 18% of all cancers, so nearly 1 in 5. For men, it's the same cancers, however, it's not breast cancer, it's prostate cancer. And here, because prostate cancer is more overdiagnosed than breast cancer, then the combined cancers is 25% in men. 24%. And that is a little more than 1 in 5. So when I talk to journalists, I usually say 1 in 5 people with a cancer diagnosis is overdiagnosed. And sorry to say it, that is thousands of people in your countries, and globally it is millions of people we have harmed in healthcare.
Okay, and we may say that was one of the reasons that we were so worried about with this new European Union proposal, because they intend to expand the target, to expand to new cancer screenings. So there would be millions and millions of European citizens more being overdiagnosed.
And you can see here the PSA screening. There's no national PSA screening program in Australia, and still you have nearly more than 40% of overdiagnosis in prostate cancer. So if you start implementing a PSA screening program here, it will grow. The same goes for malignant melanoma. So you're right, that is one of our concerns. And when you look at breast cancer screening in women, which is here, if you start screening elderly women plus 70, then the risk of overdiagnosis increases because you have a shorter lifetime left. And so that is some of our worries. And back to your case, Carlos, this is the definition of false positives. So we have an abnormal screening result, but the investigations raised no suspicion of disease, and that was exactly your case.
Yes.
Did you want to say something before I continue?
Just to share a comment from Rita Bruchado. She says, there is a lot of pressure, including from colleagues among other specialties, to screen more, particularly regarding breast cancer. I am looking forward to know what evidence drives these recent guidelines in the United States and in the European Union.
Yeah, then I think we need another webinar if we want to go through all the evidence around mammography screening. And maybe we should then invite Carsten Juhl Jørgensen, who is second author of this Cochrane review.
Just before you showed the Cochrane review, let me show you another result of another question.
Okay, I'll stop sharing.
No need. Okay. It's done. Just a minute. So in this case, we asked an asymptomatic patient without any risk factor, 52 years old, is invited to do a breast cancer screening by a mammography. And what would our colleagues consider? That the probability of benefit is greater than the probability of suffering harm. And 58% of our colleagues say yes, this is the case. Then 27% say the probability of suffering harm is greater. And 12%, now 14%, there is equal probability of benefit and harm. So let's see the results of the randomized controlled trials and systematic reviews and meta-analysis. Okay?
Okay.
Interesting.
Yeah, and they might all be right because, I mean, it depends on how you value the benefits and the harms. Here you have the mammography screening, and let me see, and this is I think the most important figure in this Cochrane review on screening mammography. You can see there are 9 randomized trials in the world. And if you look to the right at the colors, then that's the risk of bias assessment. Because Cochrane reviews, in my point of view, are the most independent and the most comprehensive reviews in the world. And they have used a great method here to do this meta-analysis. And what GREAT is suggesting is that you should do a meta-analysis of 9 of all the randomized trials you find, and that's the bottom point here. Can you see my cursor, Carlos?
Yes.
Good. So you see down here that there's a 19% reduction in breast cancer mortality from the meta-analysis of all 9 randomized trials. However, GRADE also suggests that you do a meta-analysis of all the high-quality trials, and there are 4 of those in the world, and it shows a 10% reduction in mortality. And when you then look at the biased trials that are not high quality, you could say high risk of bias or low quality trials, then there's a 25% reduction in mortality. So what do you trust? Do you trust the high quality evidence, the average evidence, or the low quality evidence? And from the GRADE principles, you should always first look at the high quality evidence. And I just want to show you that this result is insignificant. So this 10% reduction in mortality doesn't show up in a confirmatory test. The p-value is more than 5% if you use a 95% confidence interval. So if you should conclude something from this Cochrane review, you could conclude that breast cancer screening with mammography is actually not reducing mortality at all. You could also say there is some reduction. It's not very big. And another interpretation of this forest plot would be when there is so much uncertainty if there is an effect or not, then the effect is not in absolute numbers very big. Remember that I tried to teach you that we need randomized control trials with a lot of people, with a long follow-up, and only high quality. And this is exactly illustrated here. Let's say that we accept some kind of mortality reduction. Then you could look at the absolute numbers and say when 2,000 women are invited, we only have evidence from 50 to 69. We don't have any evidence from 45 or plus 70. And they are invited for biannual screening, and at least 80% come to one of those 5 rounds in those 10 years that they are invited. Then we will prevent 1 death, 10 will be overdiagnosed, and 200 or more will have false positives. So that is the benefits and harms you should balance when you value, when you assess if you think mammography screening is doing more good than harm, or the opposite.
So may we say that the probability of benefit is 1 in 2,000, and the probability of harm, at least a kind of harm, would be at least 2010 into 210 in 2,000.
Yeah, that's more than 1 in 10.
Yes. Yes.
And the most severe harm is 1 in 200. Being overdiagnosed is the most severe harm. You are not only having a cancer diagnosis, you're also having the overtreatment.
Yes, and colleagues, for those of you that are not aware or not very knowledgeable of this concept, the problem is that we have some limitations of the state of the medical art here, because when we make a diagnosis, we don't know, or our colleagues, our oncologist colleagues don't know if it is a useful diagnosis or an overdiagnosis. And they don't know, they treat every case they find. And so this leads to overtreatment, and this leads to, it's the same as an unnecessary treatment, and with a huge impact in quality of life. First, the patient will receive the news of having cancer, and this has a huge impact in the life of a person. And then he will be treated, and usually we are talking about treatments that bring a huge harm to quality of life. So we are really talking about a relevant kind of harm here. John, I believe you just answered the question from Sebastian. He was asking what ages were included in those randomized controlled trials of the Cochrane review for the breast cancer screening. Only over 50 years?
50 to 69.
Okay, okay.
And we're waiting for a UK trial, the extension trial, where in UK 1 million women have been screened between 70 and 75. And the evidence we have in the age group 40 to 45 shows no benefits, only harm.
Okay, okay. And that was the age group that the European Union wanted initially to expand.
Yeah.
So,
yeah.
So
my guess would be that you might see some benefits from 70 to 74. However, I would think that there will occur more overdiagnosis because the competing risk of dying in these women are higher because they are elderly.
Yes, of course.
I have some questions that I think we need to explore. We know that the treatment has improved during the 2 last decades in breast cancer. We know that digital mammography is leading to more overdiagnosis. So how should we actually screen in the future? We probably need to screen less than we do now, if we should screen at all. And I would suggest that we start doing research about how to de-intensivize or de-implement screening mammography. And it could be what you call a step-wedge design or a cluster randomized design where you do different screening modalities. For example, have another age group or have longer time intervals between 2 screening rounds. When I go to cervical cancer screening, there are only 1 randomized trial in the world, and it is not of high quality. Therefore, I'm using this systematic review from Canada, where our colleagues in general practice have this task force that is conducting independent systematic reviews. And you can see here there is an expected cancer mortality reduction of 35%. However, the evidence is only moderate. And if you look at the reduced incidence, we have a pretty high reduction of 65%. However, the evidence here is even worse, it's very low. If I translate that into absolute numbers, then Angela Raffel published this paper in 2003 in BMJ about, it was including the Welsh and South English, South England's population. And she shows that you need to screen 1,000 women for 35 years to prevent 1 death. And 250 of those 1,000 will have abnormal screening results during those 35 years. So there's for sure a lot of harm in our cervical cancer screening. It's really difficult to assess how many benefits and harms there are because we do not have any good randomized trials. We only have ongoing screening programs. I have one question I think is important to raise is how should we screen those women that are HPV vaccinated when they were children or sexually naive? In Denmark, we have now the birth cohort from 1995 and further on that has been offered this when they were 12 years old. And we're still screening them the same way as those that are not, we're screening them the same way, although they are vaccinated, and we're not doing any different. And I think we should start doing research about that. And I would suggest the same way as in screen mammography. Let's do some step-weights designs or cluster randomized studies where we screen these vaccinated women differently, because they have to be screened less. We know when you do primary prevention, then screening is working less effective. You will have less benefits and more harms relatively. Colorectal cancers. Yeah.
Sorry. A question from Rita Bruchado related to the Cochrane review for breast cancer screening. This meta-analysis is 10 years old. Was there any change, new evidence to lead the recent guideline changes in Europe?
I know that Carsten Juhl Jørgensen is updating the Cochrane review now, and I know that the results will only be the same or worse.
Okay, so it was not the best available evidence that made the politicians change the recommendations.
No.
Okay, but that is important to say.
Yes. And I think it's a good question, because a Cochrane review that hasn't been updated for 10 years should not actually be available according to their own rules. But I know Carsten really well, and I know he's actually just now trying to get the updated Cochrane review published. So it will soon be out there, hopefully this year.
Okay, great news. And Joanna wrote a comment. She says, I think you should also take into account that the majority of breast cancer are curable. So it would be important to see how many women are curable with surgery and don't have to do adjuvant or neoadjuvant chemotherapy that also carries burden for the patient and for the healthcare system.
I totally agree with that comment, and I also tried to emphasize that in my own questions, that treatment has really improved. And when treatment for a disease is improved or is really good, then screening is not working. That is probably why we don't have a screening program for testicular cancer. Testis cancer, why should we have it? I mean, we have a brilliant treatment. And if you have a brilliant treatment, then it's very few people you can actually help with a screening program. And because treatment for breast cancer has improved, then we probably need to screen less.
Okay, this point is also very important, and we emphasize this point in EUROPREV's statement, because actually in the last years there were huge improvements in treatments for many cancers. The problem is that in many European countries, in many health systems, we still don't have a good access for these novel therapies, and sometimes even we don't have a good access for the oncological centers where these patients can be better treated. So we believe, and we said that in the statement, that it would be a better investment to invest in this in the European Union than trying to invest in this expansion, not evidence-based screening, cancer screenings.
From this point of view, you should never start thinking about implementing any screening program if you don't have optimized your primary prevention at the structural level, and if you haven't the most optimal diagnostic programs. So if you haven't good access to diagnostic tools, investigations for your patients from primary care, and of course, as you are saying, Carlos, you need the best available treatment.
Yes.
If you have lack of resources in primary prevention, diagnostics, treatment, don't think about cancer screening or any screening program at all. Start with those three areas. before you do anything else.
And even worse is to think about implementing screenings that are not well based in the best available evidence. So without
any screening program will work fantastic in a really poor healthcare system.
Yeah, that is it.
It will be very, very expensive and a very bad prioritization, and it will also harm a lot of healthy people.
And unfortunately, it will be popular for the politicians, and it will give them votes. You are going to talk about that later.
And they will be re-elected, yes.
And we saw that in that WHO meeting that we had 2 or 3 years ago in Copenhagen. We were talking with colleagues from some countries that are still developing their own health systems. And this, what you said, is really important, because usually in countries with poor health systems, cancer screening gets popular.
They want the same fancy technologies and fancy screening programs for their populations.
Yes.
Yeah, it's very popular among lay people. Let me go to colorectal cancer screening. And I just want here to emphasize that colorectal cancer screening has shown mortality reduction in colorectal cancer in all randomized trials, when those are done in small communities. Now I want to show you what happens when you go from a randomized trial in small communities to a national screening program. And here you have the Finnish colorectal cancer screening program that was implemented, and it was followed for 10 years. And what do these Finnish colleagues conclude? We did not find any effect in the randomized health services study of FOBT screening on colorectal cancer mortality. And then they continue. So this is what we call a pragmatic study, and they randomized in clusters, the municipalities. So in some municipalities, the citizens in Finland were offered colorectal cancer screening, and in some municipalities they were not. And after 10 years, they could not see any differences in mortality reduction. We have had the same kind of study design in Denmark, but that was by birth months. So in 4 years, we implemented our colorectal cancer screening in Denmark. And it was a pseudo randomized trial on birth months. If you look at the line here that I have underlined in the results, there was no reduction among people in their 50s. Actually, they only found a reduction in mortality in men between 60 and 71. The incidence of colorectal cancer is 4 times less in those in their 50s than in their 60s. So of course, a colorectal cancer screening program will not be as effective in absolute numbers when you're screening people in their 50s compared to 60s. When you then look at this very beautiful study where they have pooled all the studies on sigmoidoscopy screening and the follow-up of 15 years, then it becomes really interesting, because here at the left corner, you can see this is the overall colorectal cancer incidence. And after 6 years, there's a primary preventive effect from sigmoidoscopy screening. So the incidence in the screening group is smaller than in the intervention group. If you look at the incidence compared in distal and proximal colorectal cancers, it is going on in the distal ones. And when you then look at the mortality, it's the same pattern. There's maybe a reduction in overall mortality. There's certainly a reduction in the distal cancers, however, none in the proximal. And this raises the question, how should we screen if we are screening for colorectal cancer? And for sure, if you look at the evidence here, you should not use fecal occult blood test or the fecal immunological tests. You should use a scopic screening and maybe sigmoidoscopy screening. This is a one screening modality. So you only screened once in your life, and not as most screening programs with fecal tests, where you're screened 10 or 12 times during 24 years. So there's also less burden on the lay people, on the citizens, if you use scopic screening. So my question here is, should we stop screening if we're using the fecal tests? If we should not stop, should we only stop those in their 50s? Or should we change our modalities to other screening programs? And I think all our countries should consider those questions and again start doing research in your ongoing screening programs if you have a colorectal cancer screening program. Because we have to optimize our screening programs and do most beneficial effects and least harm. Can I continue, Carlos?
We have a comment from Mateja Kokot. Positive and negative predictive values of tests are heavily influenced by the prevalence of the disease in the test group pre-screening probability. Maybe our future interventions should lean on prevalence that we can collect by future digital transformation.
I agree that the pre-test probability will affect the post-test probability. And if you use breast cancer screening, mammography screening as an example, then the positive predictive value for a woman in her 50s, if she has an abnormal result, will be around 10%. So 90% of the abnormal mammograms will be false positives and 10% will be true positives. When she becomes 60s, in her 60s, then it increases the positive predictive value because there are more cancer in those women, and the breast tissue is vanishing in the breasts, and there will be more lipid tissue, fat tissue, and the sensitivity is increasing, and so is the specificity. So I agree that that's a great problem with screening, that we are screening for something that is rare. So our pre-test probability is low, and therefore our positive predictive values will always be low. Most cancer screening tests have a positive predictive value between 5% and 20%, depending on the pre-test probability.
Okay, now I have questions on my own about colorectal cancer screening. Any comment on the randomized control trial that was recently published in the New England Journal of Medicine last October about the effect of colonoscopy screening
Yeah, I know several of the authors of that paper. And what is interesting for me is that the participation rate was very low when people are invited to a colonoscopy screening. And if I go back to this study, then you have a much higher participation rate in sigmoidoscopy screening. So we should really consider also that the effect of a screening program at a population level is affected by how acceptable your screening program is. So if people are not participating, then of course your screening program will not have any beneficial effects.
Right, that's a very old criteria for considering a screening program.
And I think some of the countries even had a participation rate that was in their 20s. So 28% or something like that participated in colonoscopy screening. And that is a too low participation rate to have a population-based screening program.
Okay, thank you.
If we go to the lung cancer screening, there has recently been published a Cochrane review from an Australian group, mostly based in Melbourne. I know Renee Mansell, the last author, and Asha Bonnet has just visited me. She's a PhD student. They conclude the current evidence support a reduction in lung cancer-related mortality with the use of low-dose CT for lung cancer screening in high-risk populations. And then they write those over age of 40 with a significant smoking exposure. However, there are limited data on harms, and further trials are required to determine participation selection and optimal frequency and duration of screening with potential for significant overdiagnosis of lung cancer. Trials are ongoing for lung cancer screening in non-smokers. I must say that I totally agree with this conclusion, and this is the study, the meta-analysis in the Cochrane review on overdiagnosis, and here you in a risk difference see a 80% degree of overdiagnosis in this meta-analysis of 5 randomized trials. Although I know these people really well, I must also admit I'm very critical to this meta-analysis because I don't see that the authors have taken into account the risk assessment. So they haven't looked at the risk of bias. I did a systematic review on overdiagnosis in lung cancer screening in breast. We have the same 5 randomized trials, and you can see that we did a meta-analysis at the top. Here we are calculating overdiagnosis in a different way because we're looking at the percentage of those cancers detected in the screening that are overdiagnosed. So in the top it says 38%. That means that 38 of those cancers diagnosed via screening are overdiagnosed. That's the meta-analysis of all 5 randomized trials. If I only again use the grade principles and only use those with high quality, then you have to look at the bottom, and then the German trial and the Danish trial are those that are high quality trials, and then we are nearly up to 50%. It says 49%. So translated into ordinary language, that means that every second person diagnosed with lung cancer in the lung cancer screening program is overdiagnosed. I have a lot of questions to low-dose CT screening, so I don't think we are ready to do any kind of national programs on this. Let me read out my questions and then see if there are any questions among the audience. What would be the beneficial effects of structural primary prevention of smoking if the same kind of resources used in low-dose CT screening were available in primary prevention? So what I'm saying is, if we use these hundreds of millions of euros to do structural primary prevention of smoking, what would be the benefits of that? And I know there's very little harm in structural primary prevention. Second question, how much overdiagnosis of lung cancer is acceptable? How should we recruit participants? What is the target group concerning smoking history and age? And what if you have smoked too little? And what if you developed severe COPD during the screening period? And how many screening rounds should be offered? And what should the intervals be? All these questions are, for me, unanswered, and we need answers before we can consider low-dose CT screening.
Questions? Yes, okay. We have a comment from Snezana Jankovic. The topic reminded me of the attitudes about screening from 25 to 30 years ago, when social medicine textbooks stated that screening for colon cancer and lung cancer was not recommended. So it's more a comment than a question. And then also a comment from Verla Peasons. Unfortunately, the colonoscopy screening trial in the New England Journal of Medicine shows no mortality benefit and limited incidence benefit. Do you want to comment on that?
No, I agree. And I think the reason is the low participation rate. Because if sigmoidoscopy screening is reducing both the incidence and the mortality, then why shouldn't colonoscopy do it? But of course, if only very few people are attending a screening program, you can't see that when you are estimating the average of the effect. So I agree.
Okay. In those trials that were included into systematic review and meta-analysis related to lung cancer screening, only smokers or heavy smokers entered the trials?
Yes, and it's they don't have the same inclusion criteria all the trials, but most of them start with 20 pack years, and that is, for example, 20 cigarettes a day for 20 years. It could also be 10 cigarettes a day for 40 years.
Okay.
And most of them are starting at the age of 50. And there is a non-randomized lung cancer screening trial that has a lung cancer screening program that has been published about overdiagnosis, and that was in Taiwan, and that was among women, and they saw a tremendously high degree of overdiagnosis in non-smokers.
Okay. We have here a very interesting question from Susan. Why does the United States Preventive Service Task Force, why is it recommending low-dose CT cancer screening?
You should probably not ask me. You should probably ask the US Preventive Service Task Force. I think one of the reasons is that the National Lung Cancer Screening Trial, as it is called, shows a reduction in all-cause mortality of 6%. And that's the only of all the randomized trials that have shown a reduction in all-cause mortality. And I think it has to do with the American way of having a healthcare system, because in all the European trials, we have seen no reduction in all-cause mortality, only in lung cancer screening specific mortality. So that might be a reason. When you look at, if you compare the UK's recommendations on cancer screening, they have a national committee evaluating all evidence. And when you look at US Preventive Service Task Force recommendations, there's a very big difference. In US, much more cancer screening is recommended than in UK and in Europe. So I think we have different cultures and different way of looking at our healthcare systems.
Yes, and there are some specificities, even epidemiological specificities. Sometimes the decisions are made not only based in the best available evidence, but also taking into account specificities and some characteristics that are local and for their own country. So
what I would really like is to know how the US Preventive Service Task Force is concluding that the benefits are greater than the harms in lung cancer screening and in other screening programs. They have never been transparent about how they come to that conclusion. And if you think about my slide.
Actually, it's a paradox, John, because I just last few days, I read the evidence report that is published in the JAMA medical journal, and that was the review. This review and this evidence report was the basis for their decision and their recommendation.
Yeah.
And you cannot find in this evidence report the conclusion that it's a useful screening. So
no.
It's a paradox.
The way the U.S. Preventive Service Task Force is working is that they make a systematic review where they go through all the evidence, like the Cochrane review. However, they also do a separate paper where they do a recommendation, but they never tell us how do they weigh the benefits against the harms.
Yes. Last time that I talked with someone from the United States Preventive Service Task Force, I understood that was a sort of a panel, a sort of consensus-based decision that was made. They have the panel, the scientific panel of the United States Preventive Service Task Force. When they decide to review a topic, they have special groups, companies that they procure the systematic review and meta-analysis of the evidence. Then they receive this report, and then the panel will decide according to the conclusions of the report or another factors. So this was what I understood from the way they are working, or they were at least. This was some years ago in a 1K Europe conference that it happened to be with a colleague from the United States Preventive Service Task Force. But it's interesting, this conversation, because we see many colleagues making this kind of questions. Well, the United States Preventive Service Task Force is recommending, what should we do?
And the problem is that this consensus, this meeting, that is not a transparent part of the recommendation.
Yes.
And they're not telling us how many preventive deaths equals how many overdiagnosed and how many false positives. Yes. And they don't discuss what ethics or this, how it is values based, or how they are balancing the benefits and harms. And for me, that is not democracy. This is not academia. This is the old principles of GOPSAT, good old boys sitting around a table and making decisions. And the whole paradigm of evidence-based medicine is against this GOPSAT thinking. And I think we should leave that. We should be transparent about how we come to our conclusions, and we should use arguments that is understandable.
I agree. John, we are
running out of time.
Yes, we are running out of time. Just let me share an information that is important for our colleagues. For those of you that are interested in doing all the program of webinars, we have 4 webinars, and for those of you interested in receiving at the end a certificate of attendance of this 6-hour training activity, you have to answer an attendance check form through the link that I just shared in the chat, okay? So please be aware, you have to fill this form so that we have the confirmation that you attended this webinar, and then in the next webinars we will do the same, and at the end we will send you via email a certificate. John, please go forward.
PSA screening. We have a Cochrane review here, and the most recent update was published in BMJ in 2018. There are 5 randomized trials showing a meta-analysis of 4% reduction. That is insignificant, and if I should translate that into ordinary language, then PSA screening is not reducing the mortality of prostate cancer. So no benefits. You could do cherry picking and only believe in the evidence from this European trial, and there you will find a 21% mortality reduction. But that is not evidence-based medicine, that is cherry picking. When you look at the same systematic reviews estimation of overdiagnosis, you see a meta-analysis that is hard to believe, because you have a heterogeneity of 99%, which is shown here in 3-point estimates that are very, very heterogeneous, going from 13%, 36% to 75% overdiagnosis, with an average of 39. I know why you should be concerned when you see a meta-analysis like this. And if you look at the risk assessment, you can actually see that there are problems with all 5 trials. And in relation to the risk of bias, contamination is the most important risk in overdiagnosis. And you see no green lights here. So you actually don't know a lot about what is going on. How many of the men in the control group also had a PSA test? It is reported in some of the papers. And in the American trial, the PLCO trial here, there was a high degree of men having PSA test in the control group and less in the European one. So overdiagnosis is for certain a big problem in PSA screening. And you could also see that in Paul Glacio's paper from Australia. Gastric cancer is very easy. We don't have any randomized trials. So there's a long way to go before we should even discuss screening for Helicobacter pylori.
Yes, that should be a rule of thumb. First, get the evidence.
Yeah.
And only then decide.
And then do great on that evidence, the bulk of evidence, look at the quality of evidence, look at the uncertainty, the indirectness, etc.
And look at the benefits and the harms.
Look at the benefits and the harms, like the Cochrane review on low-dose CT screening. So there's a long way to go before we can discuss this kind of screening. So if I should wrap up, I think we need reevaluation of our 3 existing cancer screening programs that is recommended by the EU. Breast cancer, we need a reevaluation because we have improved treatment. Cervical cancer, we need a reevaluation because we have HPV vaccinated cohorts now. Colorectal cancer, we need a reevaluation because we can see that fecal tests are not maybe working in pragmatic ongoing screening programs. However, we can see that sigmoidoscopy might be the way to go if we want colorectal cancer screening. We have lack of evidence when implementing screening for PSA and MII because we don't have any randomized trials that has combined those two. If we look at only PSA screening, the conclusion is don't do it. There's no benefits. Gastric screening, no evidence. When we look at low-dose CT screening, we have a lot of evidence that are lacking, and mostly the evidence around harms, but I also showed you a lot of other questions that are unanswered. The reason why cancer screening is so popular is that when you overdiagnose people, the survival rate will increase tremendously of your cancer. And people will regard themselves as saved by a screening program, and they will look upon screening as something very effective. So this popularity paradox, you need to go home and explain to your colleagues, your politicians, that they can't use survival rates when they have cancer screening. They can only use mortality rates. Finally, I just want to show you that screening and early diagnosis might increase the social inequity in societies. Gilbert Welch did this clever paper where he looked at high-income counties and low-income counties in US for 4 cancers. It's breast cancer, prostate cancer, thoracic cancer, and malignant melanoma. At the bottom, you have the mortality of those 4 cancers. It is the same mortality in the 2 areas. However, there's much more cancer in the high-income counties than in the low-income counties. This is a signal of too much medicine, too much screening, too much early diagnosing. Let me emphasize that if we are basing our values on the core principles, core values of our society, of our colleges, I think we need to reconsider and rethink our cancer screening programs, because for me, it is not obvious that we are doing more good than harm in our cancer screening programs. And finally, I just want to invite you again to come to Copenhagen in August, where we have this conference, Preventing Overdiagnosis. And with this last slide, I want to say thank you for your attention.
Thank you, John. It was a pleasure to have you with us and to see your presentation. It was a great presentation. And now,
are there any final questions or comments? I mean, we have run over time now.
Okay, and yes, we have 3 or 4 questions. I will share it.
Let us take them.
Okay, and I would like also to invite our colleagues. They can go to Copenhagen in August, but they can also come to Porto next April to the EUROPREV Forum on Prevention and Health Promotion in primary healthcare. John will be there, so you will have the opportunity to meet personally John Brodersen. We'll also have with us Shlomo Winker, the president of Wonka Europe, and other colleagues. I believe we have an interesting scientific program. So be aware, because we are ending the first early bird registration period. So come to Porto next April. So a question from Marianne. But do the results that show no reduction also mean that in these places with no organized screening people or programs still with no organized screening programs, people still have good access to healthcare, and there are a lot of opportunistic screening tests done?
We have in Denmark quite a good healthcare system, but we also have a lot of, for example, opportunistic PSA screening in general practice. I didn't mention a beautiful Danish study that have looked at one health region and looked at the relationship between PSA testing in general practice and how many patients you have with the diagnosis of prostate cancer and the mortality of prostate cancer. The conclusion is that the more PSA tests you take in general practice, the more patients you will have with the diagnosis of prostate cancer. However, the mortality is the same. And you will see a lot of harm with a lot of invasive procedures, a lot of treatment, and a lot of complications and side effects from this overtreatment. So I think it's a good comment. Opportunistic screening is not the way to go. As we previously discussed, we need good primary prevention, structural. We need good primary care, good diagnostics programs, and optimal treatment among our patients that have diseases.
I also believe that we should make some work about literacy, health literacy, and literacy about this topic, about overdiagnosis with our patients. What do you think about that?
I have done one study around citizen juries explaining overdiagnosis to lay people, and then I know Ray Monaghan's 2 papers on Australians' understanding of overdiagnosis. And I must say I'm a bit disappointed or disillusioned because people don't get the concept.
It's
On
difficult.
the other hand, I have been teaching overdiagnosis for 20 years, and I meet so many medical students and physicians that don't get it. They think it's a false positive result.
Yes.
As your small survey also showed. So we need to implement this in at least in the medical schools.
Okay, I agree. I agree. Another question from Guilherme Mendes. I'll add two other questions. How many people enrolled in lung cancer screening will use the opportunity to actually stop smoking if prompted by properly prepared doctors? Can we include that in the overall benefit of the screening?
In those countries that have run randomized controlled trials with low-dose CT, you don't see any difference in smoking habits. You don't see a bigger decrease in smoking in those participating in the lung cancer screening. However, those with false positives, they will stop smoking more than those with negative results. There is one indicator that actually a normal CT, low-dose CT result can increase smoking. There are some signals in the Dutch Nielsen trial on that. And compared, there's a Norwegian trial in colorectal cancer showing that people will eat more unhealthy if they get a normal screening result. So you could also make this joke that a normal screening result will actually be licensed to live more unhealthy. We don't know a lot about how many will actually come to the screening programs in Europe because we don't have any national screening programs yet. But we can see in US where they have now opened up in some of the insurance companies that heavy smokers can be screened, that the participation rate is very low.
Okay. And another question also from Guilherme about, I believe was the last meta-analysis that you showed. How is it cherry picking when the Schroeder protocol was different? I believe it was about the meta-analysis from prostate cancer screening.
Yeah, that's the PSA. It is cherry picking because when you do a protocol of a systematic review, where you are saying you want to look at the effect of PSA screening compared to no screening, then you should follow your protocol and include all trials having that research question. And in the world, there are 5 trials about this question. So then if you only pick out those that have the most positive results, then you are biasing your estimates and you are cherry picking. So you are taking the evidence that either talks towards doing it or against it, depending on the results. So that is against the principles of evidence-based medicine.
Thank you, John. John, we had tonight colleagues from Romania, Colombia, Armenia, Slovenia, Macedonia, Bangladesh, Austria, Spain, Lithuania, Greece, Malta, Italy, Slovakia, Serbia, Bosnia, UK, Turkey, Croatia, Czech Republic, Belgium, and Portugal. It was really, really nice to have you with us. We are receiving some very beautiful comments. I will share some of them with you because I believe you will enjoy it. For example, Sophia, thank you for this amazing talk. It raised many good questions around cancer screening. For me, as a young family doctor in training, it helped me understand what kind of questions should I ask about the diagnosis and treatment before I offer it to my patients. Michelle Anderson, Thank you. Excellent work. Rosario Falanga from Italy. Hi, Rosario. Very interesting webinar. Thanks, Carlos. Thanks, John. Best wishes from Rosario. Lucas, it was very interesting, this webinar. You have a broad point of view. Greetings from Poland. Sofia Batista, hello. So important to have this discussion and with a unique opportunity to hear from experts. Thank you to all of you and to EUROPREV. Elena Simorina, thank you for this webinar. Very interesting. Best regards from Croatia. So it's good. It feels good, John.
Yeah, it feels good to know that people gain from having these discussions, and I think this young trainee made a very important point that we need to do some critical thinking around it and just not accept the authorities and the politicians' way looking at cancer screening, because it has this popularity paradox where people think it saves lives and increases the survival rate. But
Okay.
But we need to be academic and we need to be evidence-based.
Okay, John, thank you so much. Stay well, have a nice evening and a nice week for the following days, and we will keep in touch. And dear colleagues, you may go to Copenhagen and please first come to Porto. Stay well. Bye-bye, John. And thank you very much. Dear colleagues, a nice evening for you too. Thank you for attending our webinar. See you in the next webinar. Bye-bye. Stay